Welcome to this Step 2 clinical knowledge review on dementia and cognitive disorders test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for dementia, delirium, and cognitive decline, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the neurology and psychiatry sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for dementia and cognitive disorders. Second, we will apply specific strategies for questions about Alzheimer's disease, vascular dementia, Lewy Body dementia, and frontotemporal dementia. Third, we will master the delirium versus dementia distinction, which is one of the most commonly tested topics. And finally, we will walk through multiple choice questions, just like you will see on exam day. Before we begin, make sure you have reviewed the neurology and psychiatry chapters in first aid and your question bank. This video is about strategy, not reteaching the basics. Our first strategy is the delirium versus dementia split. This is one of the highest yield distinctions on the exam. When you see a question about an elderly patient with confusion or cognitive changes, immediately ask yourself, is this acute or chronic? For delirium, the key features are acute onset, fluctuating course, inattention, and often an identifiable cause like infection, medications, or metabolic derangement. The patient was at their baseline recently and then suddenly became confused. For dementia, the onset is insidious and progressive over months to years. The patient has a gradual decline in memory and other cognitive domains, and their level of consciousness is preserved. Attention is relatively intact early on. The boards love giving you a hospitalized elderly patient who suddenly becomes confused after surgery or with a urinary tract infection. That is delirium until proven otherwise. Strategy 2 is about differentiating dementia subtypes because the boards test this frequently. For Alzheimer's disease, the hallmark is early, progressive memory loss, especially short-term memory. The patient forgets recent conversations, repeats questions, and gets lost in familiar places. Language and visuospatial skills decline later. For vascular dementia, look for a stepwise decline in cognition that correlates with cerebrovascular events. The patient has risk factors like hypertension, diabetes, or prior strokes, and their cognitive decline happens in a staircase pattern, not gradually. For Lewy Body dementia, the classic triad is fluctuating cognition, visual hallucinations, and Parkinsonism. These patients see things that are not there, have good days and bad days, and develop rigidity or tremor. For frontotemporal dementia, the key feature is early personality and behavioral changes with relative preservation of memory. The patient becomes disinhibited, apathetic, or socially inappropriate, and they are often younger than typical Alzheimer patients. Now let us go through high-yield stem recognition for each dementia subtype. For Alzheimer's disease, the classic stem is an elderly patient with progressive memory loss over months to years, difficulty with word finding, and getting lost in familiar places. Brain imaging may show diffuse cortical atrophy and enlarged ventricles. For vascular dementia, look for a patient with cardiovascular risk factors and a stepwise decline in cognitive function, often with focal neurological signs. Brain imaging shows multiple infarcts or white matter disease. For Lewy Body dementia, the stem will describe an older patient with visual hallucinations of people or animals, fluctuating alertness, and Parkinsonian features like a shuffling gait. A critical board pearl is that these patients have severe sensitivity to antipsychotic medications. For frontotemporal dementia, the stem describes a patient in their 50s or 60s with personality changes, disinhibition, or compulsive behaviors, with relatively preserved memory early on. Let us work through our first practice question. A 72-year-old woman is brought in by her daughter, who reports that over the past 2 years, her mother has been increasingly forgetful. She repeats the same questions multiple times per day, has difficulty managing her finances, and recently got lost driving to the grocery store she has visited for 30 years. Her mini mental status exam score is 20 out of 30. A brain scan shows diffuse cortical atrophy. Take a moment and consider your answer before we move on. Let us break this down step by step. Step 1. Spot the pattern. Elderly woman, gradual progressive memory loss over 2 years, repeating questions, difficulty with familiar tasks, and getting lost. This is insidious onset with a progressive course. Step 2. Apply the rule. The gradual progressive memory loss as the predominant early feature, combined with diffuse cortical atrophy on imaging, is the textbook presentation of Alzheimer's disease. There are no stepwise declines, no visual hallucinations, and no early personality changes to suggest other dementia subtypes. Step 3. Eliminate wrong answers. Choice A, vascular dementia, would show a stepwise decline with focal deficits and vascular risk factors. Choice B, Alzheimer's disease, matches perfectly. Choice C, Lewy Body Dementia, would have visual hallucinations and Parkinsonism. Choice D, Frontotemporal dementia, would present with personality changes before memory loss. The answer is B, Alzheimer's disease, Alzheimer. Here is our second practice question. A 68-year-old man with a history of hypertension, type 2 diabetes, and a prior stroke presents with cognitive decline. His wife reports that his memory was stable for several months after the stroke, then suddenly worsened again about 6 months ago around the time of a second vascular event. He has difficulty with planning and organization, but can still recall recent events with prompting. Brain imaging shows multiple lacunar infarcts. What is the most likely diagnosis? Take a moment to think through this one. Let us work through this answer. The key pattern here is the stepwise decline. This patient was stable, then got worse with each vascular event. That staircase pattern of cognitive decline is the hallmark of vascular dementia. His vascular risk factors of hypertension, diabetes, and prior stroke further support this diagnosis. The imaging showing multiple lacunar infarcts confirms the vascular etiology. Now, let us eliminate wrong answers. Choice A, Alzheimer's disease, would show a gradual progressive decline, not a stepwise pattern. Choice C, normal pressure hydrocephalus, would present with the classic triad of gait disturbance, urinary incontinence, and dementia. Choice D, Lewy Body Dementia, would feature visual hallucinations and Parkinsonism. The answer is B, vascular dementia. Remember, on the boards, a stepwise decline plus vascular risk factors equals vascular dementia. Here is our third practice question. A 75-year-old man is brought in by his family for cognitive changes over the past year. They report that some days he seems almost normal, and other days he is very confused and barely responsive. He has been seeing small children and animals in the room that no one else can see. On exam, he has a resting tremor, cogwheel rigidity, and a shuffling gait. His family asks about starting a medication for his hallucinations. What is the most important consideration before prescribing an antipsychotic? Think carefully about this one. Let us break down this answer. The classic triad here is fluctuating cognition, visual hallucinations, and Parkinsonism. Good days and bad days with confusion, seeing children and animals that are not there, and the resting tremor with rigidity and shuffling gait. This is textbook Lewy Body Dementia. Now here is the critical board pearl. Patients with Lewy Body Dementia have severe neuroleptic sensitivity. Giving them typical antipsychotics like haloperidol can cause life-threatening rigidity, altered consciousness, and even death. This is extremely high yield. Choice A, start haloperidol immediately, is dangerous and wrong. Choice B, start a low-dose atypical antipsychotic with extreme caution, could be considered but is not the key teaching point. Choice C, the patient has Lewy Body Dementia and antipsychotics should be avoided due to severe neuroleptic sensitivity, is the correct answer. Choice D, order an electroencephalogram before any treatment, is not the priority. The answer is C. Whenever you see visual hallucinations plus Parkinsonism plus fluctuating cognition, think Lewy body and think neuroleptic sensitivity. Here is our fourth practice question. An 81-year-old man is brought to the emergency department from a nursing home. The staff reports that he was at his normal baseline yesterday, but today he is agitated, pulling at his intravenous line and not recognizing family members. He has been alternating between drowsiness and agitation throughout the day. His vital signs show a temperature of 101 degrees Fahrenheit. A urinalysis shows positive leukocyte esterase and nitrites. He has a known history of mild Alzheimer's disease. What is the most likely cause of his acute change in mental status? Consider what is driving this sudden change. Let us work through this answer carefully, because this tests the delirium versus dementia distinction. This patient has underlying Alzheimer's disease, but that is not what is causing his acute change. The key features are acute onset since yesterday, fluctuating course alternating between drowsiness and agitation, inattention as he does not recognize family members, and an identifiable trigger, which is the urinary tract infection, shown by the fever and positive urinalysis. This is delirium superimposed on dementia. Choice A, worsening Alzheimer disease, is wrong because Alzheimer does not cause acute overnight changes. Choice B, delirium due to urinary tract infection, is the correct answer. Choice C, Lewy body dementia, is wrong because this is acute, not chronic, and there is a clear infectious trigger. Choice D, sundowning, is wrong because this is happening all day, not just in the evening, and there is an identifiable cause. The answer is B. The board rule is this: any acute change in mental status in an elderly patient is delirium until proven otherwise. Always look for the underlying cause, which is most commonly infection, medications, metabolic disturbances, or post-operative state. Here is a critical test-taking pearl about the workup and imaging of dementia. When a question asks about initial workup of a patient with cognitive decline, remember to order basic labs first. Thyroid function tests, vitamin B12 levels, a complete metabolic panel, and a complete blood count are the standard initial workup to rule out reversible causes of dementia. For imaging, a brain scan without contrast is the standard first-line imaging study to evaluate for structural lesions, strokes, or normal pressure hydrocephalus. On the boards, if a patient with dementia also has gait instability and urinary incontinence, always think normal pressure hydrocephalus, which is one of the reversible causes of dementia. Also remember that cholinesterase inhibitors like donepezil are the first-line pharmacotherapy for Alzheimer disease, while memantine is added for moderate to severe disease. These treatment details come up frequently. That wraps up our review of dementia and cognitive disorders test-taking strategies for Step 2 clinical knowledge. Remember to review the neurology and psychiatry chapters in First Aid and your question bank. Focus on the dementia subtypes, delirium versus dementia, reversible causes of cognitive decline, and treatment algorithms. The most important takeaway is to recognize the pattern in each question stem. Acute onset with fluctuating course equals delirium. Gradual progressive memory loss equals Alzheimer. Stepwise decline with vascular risk factors equals vascular dementia. Visual hallucinations with Parkinsonism equals Lewy body. Early personality changes in a younger patient equals frontotemporal. If you found this video helpful, please like and subscribe to our channel for more board review content, and visit roadmaptoresidency.com for expert tutors and residency advisors who can help you on your journey. Good luck on your exam, and we will see you in the next video.